Good afternoon. We'll go ahead and get started. Welcome to Grand Rounds. It's my pleasure today to introduce our speaker, Dr. Greg Siotis, who is a member of the Department of Surgery here at UMKC. Dr. Siotis completed his residency in surgery and liver and pancreas surgery for a total of 8 years at the Mayo Clinic, and currently has been on staff here performing hepatobiliary and laparoscopic surgery. He'll be speaking today about the management of acute pancreatitis from a surgeon's perspective. So please help me welcome Dr. Siotis.
Thank you. Thank you very much for inviting me in this function, Grand Rounds, Medicine Grand Rounds. That's really an honor for me, and I value that a lot. I had an interest in upper GI surgery since I was in medical school, so that was pursued when I was resident. It so happened that I got involved with pancreas and liver surgeons at Mayo. I kind of wrote some papers on this aspect, and especially with acute pancreatitis. We've done some work. I'd like to talk today about severe acute pancreatitis. And the reason we'd like to talk about that, can we have the first slide, please? Is the microphone working okay? Thank you. As you know better than I do, there is a lot of confusion sometimes on how to manage patients with acute pancreatitis. There is a lot of so-called accumulated institutional experience that may vary from institution to institution. For a long time, there has not been any rationalized, protocolized, if you will, treatment and management of these patients. And most of all, terminology has been very hard to follow. You know better than I do that terms like phlegmone, pancreatic pseudocyst, infected pancreatic pseudocyst, necrosis, fluid collection, all those things for a long, long time were describing basically some kind of bad inflammation in the upper abdomen involving the pancreas, but nothing was kind of pinned down until the so-called Atlanta classification, 1992, that most pancreatologists use today, pancreatologists meaning not only, of course, pancreatic surgeons, but pancreatic gastroenterologists. I think this is a consensus that we all use today, that some other people arrived at, and most people would use to avoid the long-standing confusion. So here the topic is management of necrotizing pancreatitis, but what I'm really talking about is severe acute pancreatitis. And how do I change the...
Remote's right under the after podium.
Keep going.
Thank you very much. In an attempt to break this down, in terms of management of severe pancreatitis, we'd like to talk about a definition. What is it? Severity, natural history, early phase management, and late phase management, and then I'll talk a little bit about infection, antibiotics, and nutrition. Is it focused okay for you?
Yes.
Okay. Before I start talking about those things, I think this is important it's important to realize that those entities are very different, and I think in order to arrive to a suggested algorithm that I'm going to present to you by the end of the talk, I'd like to spend some time to talk specifically about each one of those entities. So we'll start with definition. What is acute pancreatitis? Acute pancreatitis is defined by symptoms, signs, and basically biochemistry, meaning in most people's experience, amylase and or lipase higher than normal. Now, this higher than normal is very loose. If we have a very loose definition, if we have a high limit of normal 115, let's say, units per liter, then what is higher than normal? Is it 120 or is it 400? Most people today, and certainly in most multi-institutional studies, that people follow strict rules in entering patients in those studies. The cutoff point for biochemistry, amylase and lipase, is between 2 and 3 times above normal. So a lady with small bowel obstruction who has the symptoms and signs we can be confused with or overlapping with those of acute pancreatitis, and has an amylase of 125, which is very reasonable to have for a patient with proximal small bowel obstruction, does not have pancreatitis. So we have to have a consensus on what we mean when we say elevated pancreatic enzymes. Now, this is the definition of acute pancreatitis. Now, what's the definition of necrosis? Definition of necrosis is an imaging diagnosis, okay? And it's not that the very severe pancreatitis is necrosis. Necrosis is defined by a dynamic contrast-enhanced CT scan. I'm emphasizing the contrast-enhanced because in many people's hands, many people's experience, including surgeons, they do a CT scan for diagnostic purposes, okay, without any contrast, and you just see fuzziness around the pancreas, inflamed upper abdomen, so to speak, but you don't see dye going in the pancreas, enhancing the pancreas, or areas of the pancreas, not enhancing the rest, which would then mean that the non-enhancing areas are dead, basically, are not taking any contrast. Another important issue is the timing of the CT. There has been studies, many studies, and I grant you those are animal studies, that show that IV contrast, when administered in animals with severe acute pancreatitis, within 3 to 5 days from the onset of pancreatitis, pancreatitis gets worse. I'm going to come again to the timing of CT when I talk about early management and late management, but let's keep that in mind. Timing of CT for patients with severe acute pancreatitis should not be taken lightly. This may be an important issue. Again, I'm going to talk about that later. For the time being, amylase lipase higher than 2 or 3 times normal, and contrast-enhanced CT, not just any CT. So that's about the definition. Okay, here is a dynamic CT, contrast-enhanced CT, that shows, there is an IV contrast in, of course, which shows here's the aorta, here's the SMA going behind the pancreas, and you can see there's big, inflamed, fuzzy areas, so to speak, around the upper abdomen and the lesser sac. Okay, it's obvious that this is the SMA, contrast goes in, and you see pancreatic enhancement, which means contrast does go to this area of the pancreas, but look at that area. This area of inflamed pancreas doesn't get any contrast. Had you not had a contrast there, this area, which is now enhancing, would be identical to that. So what can we tell? Nothing. We could have the only thing we could have said in that case is that we have a big phlegmon, quote unquote, in the upper abdomen, severe pancreatitis. So what do? Nothing. We don't know anything. We have not rationalized our treatment. Now we have, though, because we know that we have a more than 50% necrosis of the distal pancreas, and the proximal pancreas is viable at this point. So that's the value of contrast-enhanced CT. Another example. Here things are worse. You can see aorta, SMA, you see SMV here, and there is no pancreas whatsoever. Nothing is enhancing. This is an almost complete necrosis of the gland. Let's talk about staging now. Staging has to do with prognosis, obviously. Which pancreatitis is worse than another? Based on what criteria? Generally, people have used Ranson's score. For reasons that I'm going to explain, they went to the IMRI classification, IMRI or Glasgow classification. IMRI is a professor of surgery at Glasgow, and he doesn't want to use, people to use his name for the classification. He wants to use his city's name for the classification. So most people would say now about Glasgow score. And there's the Apache 2 score. There's also biochemical markers, non-specific and pancreas-specific. I'll go very quickly over that in order to arrive to Apache 2 score, okay? Ranson's criteria, originating 1974, revised at 76, were based on admission criteria. You know that better than I do. And then they divided non-biliary pancreatitis versus biliary pancreatitis, and they gave various numbers and cutoffs and everything else. And there is no point in going all over this. This is in any textbook, surgical or medical. And then we have the first 48 hours criteria for non-biliary or biliary pancreatitis, and numbers vary here, and you know. And then the question comes, okay, if we use all this complicated Ranson classification, what do we know? Based on Ranson's, not definitions, but predictions, if you have a score 2 or less, then your predicted mortality in 1974 or 76, mind you, this is an important point, this is 25 years ago, was less than 1%. If the Ranson score was 7 or higher, then in 1974, it was 90% mortality or higher. Now, the criticism of Ranson's criteria is that it requires 48 hours. In other words, if you have a patient coming from Truman East, 3 days after the onset, by definition, you cannot use Ranson's criteria. You're wrong. It's a snapshot early on. It's not something that you can follow the patient along and say, okay, today we're at Ranson's criteria number, I don't know, 5, tomorrow we have 7, so we're getting worse. You cannot use that as a monitoring device. The parameters are not specific to the pancreas. Many other things can cause same elevations or decreases in the parameters. And then it does not predict specific complications. Infection, for instance, pancreatic infection after necrosis. So then Dr. Imrie, or Professor Imrie in Britain, I suppose, or Mr. Imrie, in 1984 devised his own criteria, okay? And again, I'm not going into that. Don't even write anything down. It's another classification. And people said then, okay, probably Glasgow or Imrie criteria are better than Ranson because sensitivity is about 70% and the negative predictive value is 90%. However, even if Imrie's criteria are a little better, then both require evaluation within 48 hours. Again, it's a snapshot. It's not a monitoring device. You cannot follow a patient along based on that. There was a study by Dr. Steinberg about 10 years ago which compared either Ranson or Imrie criteria and compare that to the clinical acumen of experienced gastroenterologists or surgeons. And he found, and there's no need to go all over the numbers, but basically you can see that clinical acumen is not that less important or less accurate than Glasgow or Ranson's criteria. Now, before I go to Apache 2 score, I'd like to talk about the inflammatory markers, okay? There has been many markers of inflammation that if they are higher than a cutoff point, which is arbitrary at every time, and you can choose anything you want, and many studies have chosen many cutoff points, then your prognosis is worse. And they use TNF, IL-2, 6, 8, C3, C4, and so on and so forth. I'm just presenting those things, not because you need to remember them, but because they belong to this discussion that we need to know in order to arrive to where we should arrive, I think. Then there are the biochemical markers, and they are non-specific and pancreas-specific. Non-specific means that you may have those elevations with other conditions, or you may have those elevations with pancreas-specific conditions. Of all those factors, the most promising ones have been CRP and TAP. It's out of the context of this talk to go in detail over those things. that brings us to the Apache 2 score. Apache 2 score right now in centers that Europe and United States and Great Britain that they take care of many people with severe acute pancreatitis is the staging tool they use. CRP, some people use, Ransom and Immer's criteria are falling behind or have fallen behind, I would say. Today, Apache 2 score is what most people use. And let me go over that just a little bit. Apache 2 score, assessment of severity by Apache 2 score basically is based on clinical parameters, combination of clinical parameters such as vital signs, electrolytes, arterial blood gases, age, and chronic comorbidity. The sum of those numbers gives you the score. Before I get to that, I'd like to say that the importance of Apache 2 score is that it's a physiologic score. You can use it as a monitoring device. You can say that Apache 2 score now is 7, tomorrow is 9, the next day is 13, and the next day is 7 again. So you can follow physiologically the patient. So just like you follow weight, or you follow electrolytes, or you follow amylase or lipase, or you follow whatever. So it's a great device. The other thing is that there are many studies that have used Apache 2 score to predict subsequent infection, but more importantly, mortality. There have been studies out, good studies that have proven that you have an Apache of 8 or more, you have so much mortality. Or you have Apache of 10 or more, or 11 or more, and there is so much mortality. Let me make a parenthesis and say that in the handout that I gave you, the number 4 paper that we were invited to write for a journal, a new journal, Current Gastroenterology Reports, summarizes all what I'm saying right now, especially when we talk about pancreatic necrosis in page 1, initial management, late management in pages 2 and 3. I'm going to talk a little bit about the rest of the papers that I gave you as we go along. Okay, so we talked about the definition, we talked about the severity, and now we're going to talk about natural history. What's going on with severe acute pancreatitis? Well, for severe acute pancreatitis, especially when there is necrosis, mortality may be up to 25% or even higher. We're talking today, I mean the last decade, okay? This was about 90% or 50 or 70% 20, 30 years ago. Short-term morbidity, that means either 30-day morbidity or in-hospital morbidity is about half the patients. Long-term morbidity, such as endocrine pancreatic insufficiency, exocrine pancreatic insufficiency, quality of life is about 50% of the people who are discharged from the hospital. Now, from now on, I'm going to go to the bulk of my talk, which is going to substantiate the algorithm that I'm going to pass around by the end of the talk. It's very important to recognize that there are 2 peaks in mortality of pancreatitis. And there is a very distinct and different pathophysiologic mechanism for each one of those 2 peaks. People generally, not always, but generally, die either within a week from the onset or much later. Many studies have proven that more or less patients who die early do not die because of infection, do not die because of sepsis. They die because of systemic inflammatory response syndrome, which of course hemodynamically mimics sepsis, but it's not bacteria mediated. It's not, patients do not die of overwhelming infection at that point. When they die from overwhelming infection is much later. When you have the necrosis sitting there for some time, patients were able, alone or with our medical help, to overcome this systemic inflammatory response syndrome, and then they have the necrotic pancreas getting infected, and then we as physicians or the patients cannot just go over that, and they die because of sepsis. This is bacteria. So there are two peaks in mortality. This has profound implications on how we manage these patients, okay? Because let's say if you operate on a patient like that, no matter how bad this patient is, hemodynamically or whatever, you don't have any, we're not going, as surgeons, we're not going to have any result on those patients because we're not dealing with what is really going on. What's really going on is not the dead pancreas that it's there, it's the systemic inflammatory response syndrome. There's nothing we can do as surgeons to do that, to modify that. So accordingly, the treatment should be distinguished in two phases, the early phase and the late phase. I'm going to talk about that later. So the early phase is basically directed to treat systemic inflammatory response syndrome, however, that can be treated anyway. And how do we do that? Well, we all know that we try to support patients' cardiovascular system, respiratory system, fluids, inotropic agents, ventilatory support, and whatever. Recently, we have been using inflammation-modifying agents. There are several of those, but I want to stay a little longer to the platelet activating factor antagonist, lexipafant, which in a British study published 2 or 3 years ago showed that if you give this to patients with Apache 2 score of 6 or higher, then the subsequent morbidity is lower than if you don't give it. The same study did show a trend towards decreasing mortality, but the author said that probably there is no enough patients to substantiate a statistically significant decrease. There is a study in North America which has finished and it's being analyzed right now with about 650 patients with lexipafant in 48 hours from onset. We were participating at Mayo in this study, which we hope is going to show a difference. It makes sense to show a difference because really this is a potent inflammation modifier that can possibly, if given at the appropriate stage, that can possibly treat systemic inflammatory response syndrome. So early phase treatment, treat SIRS. You see here in number 3, I put antibiotics. I'm going to come later to antibiotics. Antibiotics are very important to give at the early phase, not to treat SIRS, obviously, but to prevent subsequent superinfection that's going to manifest itself and kill the patient 10, 15, 20 days later. I'm going to elaborate much more on that, but just keep in mind that this belongs to the early phase, not as a treatment of SIRS, but as a preventive measure for the second stage. So this is the early phase. Now we're going for the late phase. The late phase is the treatment of the late phase is basically determined on the presence or absence of infection. So if the patient does okay for about a week or so, hemodynamically and everything else with what we're doing, then we have to start thinking about infection. We should not be thinking about infection before that. And because that's what's going to kill the patient and determine the outcome, basically, in the late phase. How do we rule out infection or rule in infection? Well, we have 2 ways of doing that. Basically, we need to prove presence of infection in the pancreatic or peripancreatic necrosis tissue, whatever you call it. And there are 2 ways of doing that. One is doing a CT scan and contrast enhanced again, and seeing extraluminal retroperitoneal gas suggesting either a visceral perforation, let's say from the stomach, which overlies, or from the transverse colon, or suggesting presence and action and activity of anaerobic bacteria in this necrotic tissue. I'm going to show an example or 2 of those, but this is the first method. The second method being CT-guided FNA with the modification here, with the modifier that we should be careful not to contaminate ourselves, the FNA biopsy or culture. So the message here is that the late phase, after we overcome the SIRS, then we need to think about infection, because the presence or absence of infection is going to determine where the algorithm goes, right or left, so to speak. Okay, and how do we do that? By proving infection or disproving infection. Okay, here is a patient, day 13, after the onset of severe acute pancreatitis. You can see here that here is colon, transverse colon, most probably. And in this inflammatory mass, which takes no contrast in, you see gas bubbles. That's basically a definition of infection. I mean, this gas is probably because of anaerobic bacteria living there. Same here. Same here. Same concept. If we don't have those bubbles, this is when we do the FNA, the CT-guided FNA. So, we said that the treatment of the late phase is based on the presence or absence of infection, which leads us to two possibilities. Either no infection, sterile necrosis, or presence of infection, and we talk about that in the next slide. In the sterile necrosis, when we cannot prove infection, there is no study whatsoever, no matter how bad the patient is doing, and no matter how we as surgeons feel pressed to do something as if we would change the outcome, to do something, there is no study that proves that intervention improves the patient's outcome. So in sterile necrosis, right now, most people would say that we should continue the same management as we had been doing so far. Fluids, nutrition, antibiotics, wean inotropes and ventilator, if and when this is possible. Now, this is an issue that in clinical practice is really controversial, because you have a patient in the ICU, he's not doing, he or she is not doing well for the last 2 or 3 weeks, inotropes, dopamine, epinephrine, fluids, whatever, doesn't do well, we cannot prove infection. What do? We need to do something, we need to help this patient. And I have felt personally this urge to do something, both when I was a fellow at Mayo or here, and it's hard to resist. The problem is that, as I said, if those patients were to die, if we didn't do anything, probably they would die anyway if we do something. So the urge to help in a patient with sterile necrosis who doesn't do well is not scientifically based. I do recognize, however, that including myself and other surgeons have operated on those patients just because we feel that patient doesn't go anywhere, we should do something, we may help him. But the message is that there's no evidence that we as surgeons have any influence, any impact on patients with sterile necrosis. The other possibility is infected necrosis. Well, infected necrosis means operation. If we prove infection in pancreatic necrosis, we should operate. Now, when should we operate? This is a big question. For years, the consensus was that as soon as we prove infection, we should go ahead and operate, because the sooner we operate, the better it is, and we save a patient's life, and we save subsequent complications and whatever. Now, up until one study in January of '97, the American Journal of Surgery, prospective randomized study, which took patients with infected necrosis, and they randomized them, and they said, okay, we're going to operate as soon as we prove infection in half of them, or we're going to operate as late as we can based on the clinical condition of the patient. And they had to stop the study and discontinue the study because they proved it would be unethical to continue going with the study because the results were so much better with delayed operation rather than early. After I made this slide here, there was another study from Massachusetts General, which it's a complicated statistical study, clinical study, that proved that patients with infected pancreatitis, who were operated around 30 days from onset, they have the relatively best or better outcome compared to those who are operated much earlier or much later. The trend today is for delayed necrosectomy, which then means you know you have a patient with infected pancreatitis, and you try to delay it as much as you can. What does that mean? What it really means, try to delay. Try to delay means that if the patient has infection, but hemodynamically is hanging along, and with some little dopamine and epinephrine is okay and doesn't go down the tubes, as we say, then we can buy day after day after day after day, recognizing that we're going to operate and do a necrosectomy at some point, but the later the better. Why is that? Why is that? Because necrosis is an evolving process, and the more you wait, the more walled off, so to speak, it becomes. So then, if you operate late, with one good operation, you can get over the problem, as opposed to the repeated necrosectomies, repeated operations that we have been doing for years and years, which then complicated to many fistulas, many recurrent abscesses, and so on and so forth. So again, if we have infected necrosis, we know that we need to operate. However, it's nice to try to operate later rather than sooner. Okay, what's the significance of infection? Why infection is so important parameter, factor, if you will, in order to see which way the algorithm goes? Well, many studies have proven that parenchymal infection is the single most important predictor for late mortality. I'm not saying that, all the literature says that. And how do bacteria infect the pancreas? Well, the current thought is that they translocate from the gut. And why is that? Because the gut mucosa has increased permeability when you have a big-time inflammation, that is, systemic inflammatory response syndrome in necrotizing pancreatitis. There was a very good study from Britain, which was published in Gastroenterology in 1998, that basically proved that. It did show that the permeability of the gut, of the mucosa, is much higher in necrotizing pancreatitis, and this is a human study. This is not an animal study. Okay. What do we see when we culture people with infected pancreatitis? Basically, gram-negatives and anaerobes. This you can find in any textbook. Now, another very important point I want to bring up is the use of antibiotics in necrotizing pancreatitis. I'll break it down to today, which is going to follow this slide, and to what we had known in the 70s and 80s. 3 studies around this area, around this time, showed no benefit of antibiotics in acute pancreatitis, okay? No benefit. If you give antibiotics or if you don't give antibiotics, it's the same thing. Don't worry about it. Because you may actually cause harm because you select more resistant organisms and so forth, and so on and so forth. But there are problems with these studies. Number one, in those 3 studies, patients entered whether they had big-time severe acute pancreatitis, what we would call today Apache 2 score of 10, and the little old lady who passed a little gallstone and had an amylase of 300 for one day, and then she went better. She went better, and then she started eating 3 days later. Those 2 patients were in the same group. Obviously, you wouldn't show any result, any benefit of antibiotics in those patients, because a vast majority of the patients who entered the study, who were included in the study, did not need antibiotics in the first place because they did not have severe pancreatitis. So this is one reason that those studies showed no benefit. The other reason is that they were using wrong antibiotics. Let me talk a little bit more about that. But before I talk about the right or wrong antibiotics, I'll talk about what's the consensus in the 90s. There are many studies. I'm just showing to you two here. One of them, which is the best, by far the best so far, is included in the handout, and I think it's the first one in your handout, showed that in 74 patients who did not receive antibiotics, 30%, a third of them, developed infection of the pancreas, of the necrotic pancreas. If they received antibiotic, that dropped down to 12%. P-value was 0.0001 in this study. Another French study showed basically the same thing, however in less patients. Subsequent to that, there were other studies, and a compilation of those studies are in the third article of the handout. So basically, today, when you talk about severe acute pancreatitis, where, again, you don't include patients with mild pancreatitis, in this subgroup of patients with severe pancreatitis, antibiotics do help to decrease the rate of infection. Okay, which antibiotics and how? Well, antibiotics should be administered early. As I said before, antibiotic administration is a part of the early management, not in order to treat systemic inflammatory response syndrome, but in order to prevent subsequent superinfection. The criteria for the antibiotics, for the choice of antibiotics, the correct choice of antibiotics, are based on two principles. Number one, optimal spectrum, gram-negatives, anaerobes, and maximal pancreatic concentration. This is a very important factor that we have to start recognizing more and more. Many people think that, okay, well, we have severe acute pancreatitis. What do we have? We have gram-negatives, Klebsiella, E. coli, this, that, the other. Okay, what covers that? Meslocillin, or I don't know, you know better than I do. Well, that's one factor. The other factor is, does this antibiotic reach the pancreas? Okay. We know now that imipenem followed by ciprofloxacin are the two antibiotics which combine those two principles, coverage and pancreatic presence, pancreatic concentration. By far, imipenem is the best. Let me go again to the handout that I gave you and tell you that the first study that appears in the handout showed that this 12% versus 30% infection rate is based on the imipenem. The third study that the second study in the handout in Gastroenterology 1992 goes over a kind of involved calculations, and they did show in table 4 that by far imipenem is most efficacious antibiotic for this kind of disease. So there is good evidence that imipenem and nothing else, or better than imipenem, is the antibiotic of choice for severe acute pancreatitis to prevent subsequent superinfection, because it covers the appropriate organisms and it reaches the pancreas in the highest concentration. So, how can we summarize the antibiotics issue? Early administration of the appropriate antibiotics decreases pancreatic infection and decreases mortality. And I'm having some studies here which support that, and those are in the fourth paper of the handout. Now, the recent trends to treat infection or prevent infection is that we recognize new organisms. With more and more people treating appropriately severe acute pancreatitis, we have the emergence of staphylococcal infections and yeast infections. If you have a yeast infection, mortality is significantly higher. Some people, although there is no prospective randomized study, would give, I do, personally, that's my bias, but it's only a bias, I cannot substantiate that, but I do give fluconazole prophylactically in those patients. Nutrition, last thing we're going to talk about. Nutrition is very important for pancreatitis. Prevent the catabolism as with any acute condition. It's essential for healing as with any acute condition. We have to initiate it early, and enteral is better than parenteral. So now the question is, how can you give enteral nutrition to a patient with acute pancreatitis? Well, first of all, we know that enteral would prevent bacterial translocation much better than parenteral. Many studies have shown that in many other conditions other than pancreatitis, or in addition, above and beyond to pancreatitis. I'll talk a little bit about that, basically it's pretty safe to give post-duodenal enteral feeding, provided that we don't have a generalized ileus, obviously. Post-duodenal feeding, it's a safe thing to do. It doesn't exacerbate acute pancreatitis. I put intragastric in parentheses only to, not because I would do it, but because you remember I talked about Professor Imrie in Glasgow earlier on. Well, this paper in hepatogastroenterology last year comes from his group. It has his name on 17 patients. And he gave intragastric feedings in patients with severe acute pancreatitis, not at the onset, but 3 or 5 days later. And he said that there is no difference between intragastric or post-duodenal. I want to emphasize the fact that I'm not suggesting intragastric feeding. All I'm saying is that there are significant pancreatic authorities, if you will, in the world right now who would do that. If they would do that, it's not an extreme if we do post-duodenal. The reason I'm emphasizing that is that for many people, acute pancreatitis means TPN, knee-jerk, boom, TPN. Don't even think about enteral nutrition. In many patients, that's right. When you have generalized ileus, like we had a lady in the ICU the other day, last week, generalized ileus with big-time bilious secretion from the NG tube, no. This is not an appropriate thing to do. But not all patients are like that. And in some patients, we can do post-duodenal. We have to keep that in mind. This is something that we should keep in mind today. So in summary, necrotizing pancreatitis and severe acute pancreatitis remains a very severe condition no matter the progress we've made. The diagnosis of necrosis is based on dynamic CT, contrast-enhanced CT. Diagnosis of infection is based on FNA. Initial treatment is directed to systemic inflammatory response syndrome. Late treatment, prevent and treat sepsis. Appropriate antibiotics early, and beware of new problems such as yeast infection and other things. This is the end of the talk, and all this, I think, would serve as a good introduction or a substantiation of why I would suggest this algorithm for the treatment of severe acute pancreatitis. Okay. Sorry about that. You see, I divided this algorithm in two parts. Number one is suggested algorithm for management of acute pancreatitis, and the second is suggested algorithm for management of severe acute pancreatitis. Let's go to the first one. We need to make a diagnosis based on symptoms, signs, an amylase and or lipase between 2 and 3 times above normal. Then, after we have a staging, we go for the, after we have the diagnosis, then we go for the staging. Most people would use Apache 2 score, and this 6 that I put there, more than 6 or less than 6 can vary. Some people use 8, that's fine too. There is a handout that we're going to circulate, and this is exactly this page, and we're going to pass around. Now, if it's mild, no problem. Patients are going to go home, mortality is almost 0. But how are we going to rationalize the treatment of severe acute pancreatitis, which is more than 6 or more than 8, and this varies from institution to institution? Well, the ways are what I have put over there, and I suggested intensive care monitoring and support for the systemic inflammatory response syndrome. At the same time, start the appropriate antibiotic early. I would put fluconazole, but I put it in parentheses because that's my bias. There is evidence in the literature, but there is no prospective study to convincingly, to convince us about it. Post-duodenal feeding, my #1 priority. If I cannot do that, then I go for TPN, not the opposite. Then, 5 to 7 days later, CT with IV contrast. It would not make any sense to do it earlier because no management decision would be based on a CT which is done early. If it's necrosis, okay, it's necrosis. It's 5-7 days. It's systemic inflammatory response syndrome. What are we doing? Nothing. It doesn't influence our decision making and it may harm the pancreas. So CT 5 to 7 days later. FNA culture, if negative, continue same treatment. If positive, we'll need operation. Later, better than sooner. And then operate as late as possible. This is a suggested algorithm which is obviously amenable to all sorts of modifications. This is, again, suggested. It's not the gold standard by no means, but I can tell you that Mass General has adopted something similar to that. The only difference is they put 8 here instead of 6. And their mortality has gone down over the last 3 years to 7%. Now, this is severe acute pancreatitis, okay? 8%. There is a great pancreatic center in Bern, in Switzerland, that has with the same algorithm, and they have 6 here, not 8. They have gone down to 6%. Now, those are impressive numbers. I suggest that, but it's up to all of you. Thank you very much. Yes, sir.
How can we, or could you speculate a little bit on, when we look at this problem, when to operate on someone that we know is infected? And I think all we can conclude if you get 10 people together is that we don't know the right time yet, and that what we have been thinking is not as right as we thought. And to me, the problem with early surgery is not that the operation is a failure. I think that they're a complete success. But the problem is that the inflammatory response that's allowing translocation is still there after you operate, and they are simply reaccumulating infected material. So that's why timing is, but what kind of clinical markers? To me, the logical way to go would be if some of our measurements on bowel permeability. But is there any interest in the surgical world in looking at as a guide to when to operate?
That is a great question. That's a great question. That's a great concept. It's being worked. I showed you a paper from UK which showed that the gut permeability is higher with necrotizing pancreatitis, a clinical study. The subsequent paper of that, which is not published yet, but I know the authors and they are talking to me about it, is that that's exactly what they're doing. They're giving PEG, radioactive PEG, in various time intervals, and they measure permeability as a monitoring device.
And there's a million ways of doing that. There's no standard
yes,
in history.
But my answer to you is that yes, the concept you're bringing up is a great one, and people who have pioneered this clinical method, they keep going exactly to this direction that you're suggesting, in order to see when that gut permeability goes down again. So when this whole process is kind of finished. Mm-hmm. So then we can operate more safely, just as you say. Same concept. Is that what you're? Yeah. But I mean, that's a great point. Do we do that? Does anybody else do that? Personally, I'm not aware of any center other than that one in the UK which started that.
There are several people that have been looking at sucrose permeability.
Okay.
And that's so much cheaper. That's why.
Sure.
Not because we think it's better. It's just cheaper.
Yeah. And
so far, we haven't actually got any data from the surgical side because we haven't sold anybody, but that's a good idea.
Personally, I think it's a great idea.
One other thing, you're kind of down on the idea of intragastric and it's not that I'm in favor of it, because I'm not sure whether it works, but I don't see any reason to be too pessimistic about it, because I think if you can get people beyond the point where no enteral feeding is going to work anyway because of the lack of motility, once you get beyond that phase, I don't know of any clear data that says there's such a major difference in the effect on intestinal motility versus gastric emptying. And I'm not sure that they're separate. I don't think it's inherently a bad idea to try intragastric feeding.
Dr. Smith, I'm flattered. I mean, you're far more progressive than I could have been from this podium here, because I wouldn't agree more. However, you have to realize where I'm coming from. I'm coming from the standpoint that most people would react in a knee-jerk reaction, so to speak, knee-jerk way, acute pancreatitis, TPN. In order to go for acute pancreatitis to post-duodenal feeding, in some people's mind, this is a heresy.
But
if you go to you, well, allow me to say, I am working with metabolic support service over the last year and a half here, and I've seen that time and again. Acute pancreatitis, TPN, and we try to say post-duodenal feeding, and we meet some, not resistance, but how can you feed the gut? So coming from that, to go ahead and suggest intragastric, I mean, they're going to put me on fire. You know what I mean? Inquisition. So I said, okay, post-duodenal. That's what I would do. But I wouldn't agree more. After a point, intragastric is great, yes. I couldn't agree more, and thank you very much for the comment. Yes, sir.
First, I have lots of questions about your antibiotic comments. And the first one, I guess, is the study from Italy chose a select group of first demonstrating radiographically that they had necrotizing pancreatitis, and then showed a benefit in giving that group antibiotics. But in your algorithm, you just base it on
Apache
antibiotic scores on the basis of Apache scores. Why the difference?
Well, the difference is because if we show, I'll tell you why. If we show good results of imipenem on the severe group, and we do not know which of the Apache more than 6 are going to go to necrosis, we're better off covering those people with the appropriate antibiotic for necrosis in order to prevent it. And that's the trick, and that's the idea. And that's the idea. And the question would be, what would you do if you don't do that? Then what, you give some other antibiotic, wait for the necrosis, which then the rate may increase, the infection may increase on that necrosis, and then give the imipenem, which wouldn't do anything anyway at that point. So really, how many patients do we have with Apache 2 score more than 6 or more than 8? Very few, not very many. So the expense, if you will, of giving imipenem is not that big. But the prevention, the decrease of the risk of subsequent infection and subsequent hospitalization and morbidity and mortality of patients on whom you could have prevented infection by overgiving.
But you don't know that actually, because the evidence is just in those that have demonstrated necrotizing.
My response to that would be that we have very good evidence that in necrotizing pancreatitis, imipenem does make a difference. This is, I don't doubt that, and most people don't doubt that.
I'll ask one question about that.
So I would try to give this antibiotic to the people who are more prone to develop the necrosis, on which I do know that imipenem is much better. I wouldn't be so liberal to allow for more people to go to infection just because I'm not giving imipenem at the right time.
I mean, it assumes that there's no ill effects of giving antimicrobials.
Well, but I mean, if you ask this question, you also have to support it with some literature.
Right.
And I don't think in this context there is convincing literature in not to giving imipenem right now.
I guess I would argue there's no convincing evidence to give imipenem for those that have Apache scores more than 6 but don't have demonstration of necrotizing disease by radiographs. But I have a question. Why do you think in the Italian study that the use of antibiotics didn't decrease the need for operations?
I'll tell you why. I'll tell you why, because in those patients, this is earlier study, as you know, the concept of delayed necrosis, of delayed operation, number one, and the concept of trying to avoid an operation altogether in sterile necrosis had not come up. This is an evolving process, a recently evolved concept to try to avoid an operation in sterile necrosis. When they did the study and when they wrote the paper, this was not a concept that was prevalent. This was not a popular concept, if you will. So you had necrosis, it meant operation. Right now, it's not exactly like that. You have necrosis, if it's infected, that means operation. If it's sterile, you may go without an operation. So that study reflected another era, another concept. That's why. Yes, sir.
Giving antibiotics is contingent upon the Apache 2 score. When do you recommend that that particular score be calculated in the course?
Oh, on admission. On admission.
So everyone with a score greater than 6 immediately receives a course of antibiotics.
As I said, in centers that they have rationalized, protocolized treatments from the ER to gastroenterology to surgery, and they all follow the same algorithm with either Apache 6 or 8 in the two groups. That's exactly what they're doing. Apache 2 score at onset or admission, realistically, then you go towards this direction. Yes, sir.
You had suggested waiting as long as possible to doing surgery, and the data that you said for Mass General was about 30 days.
30 days.
30 days. So would you suggest keeping them on prophylactic antibiotics until the time of surgery?
Well, not in prophylactic, but imipenem has proven its role in prophylaxis, prevention of infection, okay? If you do an FNA, and you know exactly what's going on, then the antibiotic is going to change by the results of the culture. The imipenem is not something that you should continue on and on and on and on. It's something that can be modified based on the FNA. Mind you, those people who have the infection, it's a proven infection. They proved it somehow. They put probably they did an FNA and they cultured something. So the subsequent antibiotic is chosen based on that culture.
But if the FNA was negative, you would continue to do that?
Personally, I would, yes. Because I'll tell you why. If you ask me, can you justify that? The answer is no. But why not give it if I can prevent something? Do I know I prevent it? No, but what am I losing?
But what you're saying is if you were going to wait 3 weeks, in other words, to do surgery, you would keep the person on. And
I have a proven infection or not?
Let's say if the FNA is negative.
If the FNA is negative, I would try not to operate. However, I would keep this patient on antibiotics, yes. And the best data we have is that imipenem prevents pancreatic superinfection. That's the only evidence we have, and that's what I would give.
And when would you stop?
When the patient does better, starts doing better. Yeah.
If your patient, due to say renal disease, is not a candidate for contrast, is the CT still helpful, or is it used?
The CT is not going to be very helpful other than guiding your FNA, but it's not going to show you extent of necrosis, presence or extent of necrosis, because you don't have IV contrast enhancing the pancreas. Another important thing is that many of those patients have renal disease early on, and then they kind of become better, some of them. And if you choose to do a CT scan with the first week, when the renal disease is likely the worst, then it wouldn't make any change whatsoever. I mean, it wouldn't make any change in the management. Okay, but if you waited for a week or more to do your CT, then maybe the kidney function be better, which would then allow IV contrast. But to answer your question is that if you are forced not to use IV contrast, don't use IV contrast, but don't expect to define necrosis. You can define infection at that time.
Does an MRI help?
No study has shown that in this context. I mean, of course, you're right that MRI is picking up pace with pancreatic and liver processes, but Not that I know in necrotizing pancreatitis or severe acute pancreatitis. Thank you very much. Another one.